Yes, good morning and welcome to video 31 of the Tulip Airway video series. Today what we're going to do is look at a sedation study from Japan that came out in March and April of this year. We became aware of it about 2-3 weeks ago. It's 647 patients and shows the kind of versatility of Tulip because we've had reports of cannot intubate, cannot oxygenate. Times 10 cases in another study, which I'll bring to you later. So this study, using the Wiley online library to look at this, but this is a Japanese study called Safety and Feasibility of Deep Sedation with a Tulip Airway and their jaw elevation device, they call that the JED, during electrophysiology procedures, right? So this is single center, 647 consecutive cases, okay? So the paper is about using deep sedation for electrophysiology procedures. You're talking about AF, ablations and the like. Now they're using the Tulip Airway in conjunction with this jaw elevation device, which they call the JED. It's a retrospective study and it's basically analyzing 647 patients, right? But these are patients that they're not anticipating a difficult airway with. Okay, and of these, 634 were AF ablations and 13 were left appendage closures, right? So the end of the study would be when the procedure was completed, or if the patient needed to be intubated, or if they had to stop sedation for some reason, like, procedure-related complications. But note, the results, all procedures were completed. Right, so one patient needed intubation. They said that's likely to be COPD related, and 3 patients experienced procedure-related complications. Now, that's the reference to go straight to this. Now, clearly on screen it's not worth much to you, so it's in the description as well. So, this is what we're looking at. Now, the introduction. Patient safety and procedural stability are essential, right? Because you need to basically control the catheter. So if you're doing something like a LAC, which is left atrial appendage closure, the patient needs to be still, right? But this is important here, and this seems to be kind of, I'm not sure if it's country specific or not, but owing to a shortage of anesthesiologists, administered GA is not readily available in Japan, right? Now, and this is really important to me because consequently, cardiologist-led deep sedation, often using propofol and airway devices, has been widely adopted, given a reference for that. So this is airway management by non-anaesthetists. That matters. And it says here, although the IGL is commonly used in Japan, its design limits oropharyngeal space because it's large and bulky, so you can't get the trans-esophageal echo in, right? So it says that, making TEE. Now, for us in England, it's TOE, but it's impractical because you just can't get it in. Therefore, they developed an alternative propofol-free. Okay, so this isn't, TIVA. This isn't a running anaesthetic, but it's a deep sedation strategy that allows the use of trans-esophageal echo when they need to, because they want to observe the cardiology output whilst they're doing their ablations and their closures. So this study is evaluating the safety and the feasibility of using a Tulip with a jaw elevation device. Okay, and it's a single center, 647 cases. Now, it's a single center retrospective study, and it's prospective observational studies of atrial biopsy patients and patients with AF, including 707 patients undergoing AF catheter ablation and 50 patients undergoing LAC. Right, June 20, November 25. No, they didn't use anybody who was seen at other institutions, and those who needed general anaesthetic were also included. Right, so there was left a 647 cohort who underwent the deep sedation with the Tulip of the JED. Now, what's important is that high-risk patients were not in the study. They were basically given a GA. Deep sedation they're defining as being enough of sedation to permit external cardioversion without patient movement awareness. So that's quite deep. Right, now notice what's happening here is that this is being administered and supervised by a cardiologist, not an anaesthetist, which is actually a really big deal to me. Okay, so anaesthetic personnel were not routinely involved. All patients were oxygenated, all monitored. Then they used fentanyl, midazolam, and something I've never used before. And then they basically administered a shot of thiamyl sodium just before the transesophageal echo was introduced. But once the patient was unconscious, the Tulip size 2 was used. That's the green one. And its cuff was inflated to 20 to 40 mils of air. Now I've noticed this, and basically a green Tulip requires 50 mils of air. So maybe what they've done here is they've used less so that they can get the transesophageal echo in. Now I did wonder originally why they didn't put it through the tube, but the transesophageal echo is about that wide, so I can see why they didn't. But then basically when they needed to use the transesophageal echo, they inserted it through the piriform fossa under fluoroscopic guidance. Now that means down the side of your throat. And this is really just to sort of minimize stimulation. They were monitoring all the way through, and they used fentanyl every 30 to 40 minutes just to kind of reduce the responses, and using about 10 breaths a minute. Okay, and then this is the part I'm not quite sure about. It says when SATs fell below 90, manual ventilation was performed using a bag valve mask. Well, I'm not sure if that means they're taking a Tulip in and out. I'm not quite sure. So this is the drug that I never heard of before. So basically, I don't use this, but basically this is called Dexmed etomidine from what I can see. Now this is basically the video of the transesophageal echo that they've very kindly attached to this paper online, so you can watch this for yourself. But if you look at the width of the distal end of this transesophageal echo, you can see you can't get that through the end of a Tulip. So they're going round the cuff behind the back, I trust. So here's an image that's included in the paper. You can see a Tulip GT. Now GT stands for Goodell type, you can just call it a Tulip. But you can see that it's a double limb attached to the Tulip here. That's the jaw thrust device which holds the jaw open, and the Tulip's in situ there. There's the Tulip, there's your double connector again. That's the setup, that's a green size 2 Tulip. Notice no headband here because they want kind of more access, and that's what it's for. And there's a double Y piece attaching to the CO2 monitor, etc. Stability. So the endpoints were feasibility and safety, right? So, and that was assessed on, whether they could complete the procedure or not, and of course, whether complications or a conversion to intubation or they had to stop or something like laryngospasm was also noted. They'd recorded the procedural time. So 647 patients, mean age of 67, right? So they underwent either an AF or a LAC. Now there's 634 AFs and 13 LACs. Now there's a table to follow that will show you. The oxygen saturation fell in 9% of those patients, right? Where by only 8 of them, which is 1%, they needed to be bagged or masked. Now again, I'm not quite sure how they did that. They could have just ventilated through the Tulip, but I'm not sure what was happening here. I'd love to hear from the doctors who did this. Now only one patient needed to be intubated here, and they, as I said at the beginning, they think that's related to COPD. Now there were complications which were related to the procedure in 3 patients, right, and that's 2 tamponades and 1 phrenic nerve injury. So these procedures are lasting between 148 minutes and 24 minutes. So that's like, half an hour to more than 2. And that, again, AF ablation and for the LACs. Now, hypertension, which isn't airway related, was required in 22%. Now here I looked at this, the age of 67 plus minus 11, BMI is actually about average, I'll show you. And you can see that there's a reasonable prevalence of the normal standard type of secondary conditions. Now, I looked at the BMI, and particularly for Japanese adults, depending on stature, height, all the rest of it, and basically it comes out as the range that they've used is approximately, average. Now, those are the numbers of procedures, as I said, a majority were AF ablations, etc. This is the sedative elements. Now, it says that the study demonstrate that propofol-free deep sedation using a Tulip Airway and a JED is safe and feasible. Okay, of course, carefully selected population, but they're referring, specifically to things like electrophysiology procedures. They've gone on to describe the usefulness of the JED and the Tulip individually. Now, those papers, basically, they're quoting there is one of them is ours, and the other one is from someone else, and I'll show you those at the end. Now, but notice that what they're particularly happy with is that when they use them together, there was a high procedural completion rate. Okay, so the trans-esophageal echo is successfully performed in the 41 patients, and the sedation strategy was considered acceptable when done by cardiologists, which I think is, kind of important. So, what were the limitations? Single center, retrospective. Okay, fair enough. We know that's fair enough. Patients, with anticipated difficult airways and obesity, they were removed, which is fair enough, and they, of course, they use standard line, we need larger multi-center studies, of course. So what was the conclusion? Deep sedation using a Tulip and a JED is feasible for electrophysiological procedures, right? Particularly things like trans-esophageal echo. They talk about the funding, which they've got from the Research and Development Agency, and the ethics, of course. Now, conflicts of interest. This is interesting. One of the authors is being paid by Abbott, but we didn't. So happily, the authors are free of any prejudice towards Tulip. Now, these are basically the availability of data. The top link here is in fact a video, the one that I showed you. So this is that video again. So these are the references they quote. That's number 5, which is us, of course. That's the one at the top. Now, that's basically, that link is in the description that takes you to this study. Now, just to show you again, the reason you can do sedation with Tulip is because it sits in the oropharynx, glossopharyngeal nerve, so it's very low stimulation, much less than an eye gel, as you can see, which sits right down here in superior laryngeal mask territory. I mean, if you look at the two, it's fair to say that a Tulip sits where an eye gel just doesn't, because an eye gel is sitting here, isn't it? So a Tulip literally sits above it, doesn't it? I would say. So if you want to use a Tulip in an awake patient, all you have to do is use lignocaine spray. Wait about 3-5 minutes. I mean, what they're doing with colonoscopies at the moment is they're putting them in, they can attaching them just as a basic airway, because even when it's not inflated, it's better to tell, and it's directly connected. But they don't inflate it until they need it, and if they do, they do, and if they don't, they don't. So here are 2 other videos that I refer you to. One is about sedation, and the other one is about semi-conscious airway management. It's not quite the same thing, but it's the same conscious level, I would say. So that's the Tulip website. See you on the next video.